then substance abuse, cocaine, meth, all these horrible street drugs can cause heart failure and heart damage and lead to heart failure, and it's really sad. And I think it should make sense to you that extreme obesity over time works the heart too hard. And when you have a patient that's 700 pounds, do you think their heart is really having to pump? And so that should make sense to you. And then severe lung disease, if the blood can't flow through the lungs like it's needing to, you think that's going to be a problem if the pressure's high there? Yes. All right. With heart failure, the main lab is what?
BNP.
BNP, the main one I talked to you about. But we also look at these other labs, and that should make sense to you, that can affect heart failure. Your sodium, what is sodium so big at? That determines
Brain.
It determines fluid, right? Whether your fluid's going to stay in your intravascular space or go to your tissues. And so, again, if you're spilling albumin or protein in your urine, that would be from heart. Your heart is not functioning correctly. ABGs, what does ABGs tell you? It's oxygenation, if they are able to perfuse. Chest x-ray is going to tell us if there's fluid in the lungs, how big the heart is. And I want to ask you something. Echocardiogram can tell you a whole lot about the heart, and it does. And one of the things that I might say is like left ventricular hypertrophy. What does that mean?
It's decreased muscle mass.
Decreased?
It's
They got a big old heart.
Big old.
And so they got a big old floppy heart. And if it's on the left side, left ventricular hypertrophy, what side of heart failure are they in? Left. If their cap refill is greater than 3 seconds, are they perfusing well? No. If it's left-sided heart failure, and you know that because it said left ventricular hypertrophy, then what is your priority assessment?
Lungs.
Lungs, like respiratory rate and effort. Good. Just seeing if you can process. All right, so the best diagnostic tool in heart failure is your echo, because your echo shows you the size, shape, function, motion. You can see all the valves. An echocardiogram is just wonderful because it's non-invasive. Of course, your ECG or EKG is going to show you the electrical activity, and that invasive hemodynamic monitoring is fabulous. And we're going to talk a lot about that next semester, but you're responsible for those 3 things. Remember? Cardiac output, MAP, and what? CVP? Okay. So, with heart failure, it is so important that you understand that if your patient has an exacerbation or is in acute heart failure, you can't get them up and push them. If they can't hardly breathe to talk, you better give them a bedpan. If you push them to try to use that bedside commode, you're going to kill them. And are they going to, really, they can have a life-threatening dysrhythmia if you push that hard. So understand that we'll let them use that bedside commode once we get them managed with Lasix, furosemide is what y'all call it, and medicine, and they're doing better. And now there's other teaching that I wrote up here on the board that y'all sometimes forget. So when do we report how much fluid is too much overnight?
2 pounds.
Yep. So it's okay. I mean, no more than 2 overnight. How much in a week?
3.
3. You got to know that. 3 in a week. 3 in a week. How much in 2 weeks? It's not a trick. I couldn't help myself. Sorry. 6. That would be 6. Considering that we couldn't divide 3 into 130, thought we should try that. I don't like math either, but we have to do it. All right. You're like, just give me my phone. All right. So we talk about how much weight is too much. You need to know that. I wrote it on the board. How much fluid, if someone has heart failure, true heart failure, significant heart failure, how much fluid should they have a day? I brought this in here, I stole this, I reallocated the resource from the break room. I don't even know who this is, but I wanted to give you a visual for you visual learners.
They're on fluid restriction.
They are on fluid restriction, and how much fluid restriction?
2 liters.
2 liters. And I did home health for 3 weeks, so I am the expert, let me tell you. And I had more fun, but I never went home when I worked home health. So I don't have the personality for it. I had more fun teaching heart failure patients about fluid restrictions. And they would go, I don't know what you're talking about when you say 2 liters. And I'm like, you're lying. And they go, and I've already established a relationship, so I can say that. You know, I've been doing it for 3 weeks. But anyway,
How many times over it? I can't see it.
1 to 2, so it's 2 is the max. So look, but you're gonna report that. If they're doing 2 pounds in 1 day, that'd be something you want to tell somebody. Especially if it's more than that, and usually it is, unfortunately.
So you report all of that?
Yeah, it's too much. Yeah, if they've got more than 3 pounds in a week, it's too much. Okay? More than 3 pounds. Okay, listen. Let me tell you what I used to do. I'd say, you lie, and I go, what is that over there on your counter? And what do they say? A 2 liter Coke. And you don't know what 2 liters is. And so then I would go, do you have a funnel? And they go, a funnel? My husband might have one. I said, we're going to get you one. I'm going to bring you one. I can get them at the dollar store. So I take a funnel. I empty out. I said, when that gets empty, you save it. And I get a funnel. And I say, every time you drink something, I want you to take whatever you drank that out of, put water in it, and pour it into this empty bottle. And you're going to see when you're getting close to where you can't have nothing else today. And you're going to do it just like this. And when I come back next week, I bet you we're not having to call the doctor to get you extra medicine. If you follow those directions, we're gonna be good. So this is how you teach people, because they'll say, I don't know what 2 liters is. And you go, well, what is that? And then some of them don't have that, so I would bring an empty one to their house. And I would bring them a little funnel. And I would say, every time you drink something, you pour the exact amount that you drank in there. And when you're getting close, you know you ain't gonna have no more tonight. All right? So do you understand why you have to do stuff like that? Mm-hmm. So you're going to teach them to do daily weight, correct?
Yes.
And low sodium diet, correct?
Yeah.
Okay. And understand that heart failure is one of those core measures that at hospitals we have to meet it all, or they get in trouble. All right. So you understand about activity. If they're exacerbated, they rest. If they're in an exacerbation of heart failure, they get no IV fluids. You better question that.
Yeah.
All right, so what are the drug classes we use? They're all up there. You should know furosemide, like the back of your hand, and what hypoxia symptoms and hypokalemia are. And you should know about lansoprazole, ACE inhibitors, and beta blockers. So anyway, if a patient is in heart failure and they're in the unit, we're going to be listening to their lung sounds every 2 hours, and sometimes every hour. And if they're getting better, then their crackles, they're getting better, they should be diminishing, right? So they should be going back down if they were up high. Do y'all understand that? Do y'all understand? All right. So again, we want their O2 sat greater than 90. And if they're not, they can't breathe because there's so much fluid in their lungs. Let's say your patient went into pulmonary edema. Then they're going to end up on a ventilator, and you're going to learn about ventilators in level 4, and they can put a high pressure on their ventilator to push the fluid out of their lungs. Isn't that cool? Okay. So we're going to give meds if they're in heart failure. We're going to do a lot of education, hint. And we got to monitor whether the meds are working or not. And then we'll drop that special line in the patient, and we can tell whether our meds are working. All right, so there's some information on digoxin. You should be able to teach that. You've had that forever, and some more information on digoxin. Wonder why that's there. All right, decrease in fatigue and weakness. On every care plan on a heart failure patient, you should have allow for frequent rest periods. Does that make sense? Do y'all understand that? Allow for frequent rest and progressive activity. Remember we talked about pulmonary edema? Look at this. It's everything we talked about, isn't it? If your patient's not on a specialized cardiac unit and they go into pulmonary edema, they're probably going to go to the unit or a specialized cardiac unit to manage it, unless the nurse is just super cool on that unit and know how to manage this without freaking out. All right. There's some information on diuretics. Furosemide is a loop diuretic. Hydrochlorothiazide is a thiazide diuretic. What is spironolactone?
Potassium
Potassium
sparing.
sparing. Very good. All right, just checking. So how do you know the heart failure is getting worse? There's all the ways you know it. What's awakening at night? When they start awakening at night, suffocating called? Paroxysmal, nocturnal, dyspnea. Y'all remember that?
No.
Level 2. I'm fixing to put my lip out. When they go to bed at night and they have heart failure, what they do is all their fluid from their extremities start coming back up to their heart, and the heart can't handle it. And so it kind of puts them in a flash, a little bit of, they suffocate when they're laying down. And so they'll have to jump up or walk to get better. Yeah, it's interesting. Okay. I'm not doing the case studies. We don't have time for all that. Y'all can go through them. If you don't know the answers, I'll be glad to give them to you. It's not necessary. All right. Everybody take a deep breath. Because we're fixing to hit it. So let me tell you first what we're going to hit. I'm going to hit the real high points, and then I'm going to come back when we come back and make sure you got them. Okay? Because I know it's Friday and your brain is like mush. It's gone. So let me at least tell you about the atrial rhythms that you are most responsible for. And that way, if you're studying this weekend, you'll know where to concentrate. Is that fair?
Yes.
Okay. So we're talking about electrical conduction of the heart. So what you're seeing on the EKG strip, and you learned hopefully in LPN school or last semester what the normal rhythm is, normal sinus rhythm. And you know you have to be married to normal before you can recognize something that's abnormal. So this semester we're going to do atrial dysrhythmias, and there's a bunch of them, but we're not going to concentrate on a bunch of them. I'm going to show them to you, but I'm not focusing hard on them. So the ones you're responsible for, first one's not even a rhythm. It is an ectopic beat coming from the atria. Ectopic means outside the normal conduction, called PACs, premature atrial contractions.
Can you say that more?
Premature atrial contractions. Sounds like a woman in labor to me. All right. Y'all ready? Okay. Where is that irritated site coming from? Where does it tell you it's coming from? The atrium. Okay. We just talked about heart failure, didn't we? So in heart failure, you got a lot of blood pouring into your atria, and it's stretching it, right? Could that cause irritation in that atrial tissue? So one of the causes of PACs is what? Fluid overload. Now the most common cause of PACs, which is hilarious, I should just say nursing school. Coffee, caffeine, and nicotine, and stimulant stuff. So that's why I said I should just say nursing school. The other stuff is like anxiety, and all this is on these slides, I'm sure, but I'm telling you this to say the most common thing you're going to see a lot of there's a couple of things. PACs, if your heart is normal or regular or is healthy, PACs mean absolutely nothing, okay? But if you continue doing stackers or you continue doing diet stuff and caffeine, they're going to continue. And they can lead to something else, is what I want you to understand. So when we see PACs and they're pretty frequent, we go to the patient, we go, are you in nursing school? No, I'm kidding. We say, how much caffeine do you drink? How much coffee have you drank? Are you taking any sinus medicine or something I don't know about? We teach people with PACs to abstain. What does that mean?
Stay away from.
Caffeine, nicotine, and stimulants. And typically it's funny because they'll kind of start subsiding and they'll go, oh, no, I don't do none of that. You know, and their coffee's sitting over there. No. But they go away after you teach them. And so, because what have they done? Eliminated the cause. So with PACs, you treat the cause. So I told you another thing that causes PACs is anxiety. So if you've got a patient fixing to go to surgery and they're scared to death, give them something for their anxiety. And one of the first things they like to give them at some surgery centers, which cracks me up, is Versed. They're like, how about a fast-acting Valium IV? We can fix your problem right now. Because that's what Versed is a benzodiazepine IV. Valium's a benzodiazepine. And so I just laugh because, I mean, your PACs will just disappear, you know? It's amazing. And so, again, PACs, anxiety, PACs commonly are caffeine and nicotine. Can be from fluid overload. So do you see how we don't get upset if you have a healthy heart and have PACs? We get very upset if you have a sick heart and start having PACs because we got to get rid of them. If it's fluid overload, what can we give them? Furosemide. And it's amazing because the PACs will start diminishing after you fix the cause. So we treat the cause. Got it? Okay, the next one, most common chronic arrhythmia. Most common chronic arrhythmia. Chronic means they're going to have it for a while. It's not easy to get rid of this one. And that is, and if I told you it's the most common, it's also the most commonly tested everywhere. Hint, atrial fib, atrial fibrillation. And a hint to you at clinical, if you got an ICU nurse going, hey, what do you see up there on that monitor? And it's irregular and you're not sure what it is, just guess atrial fib and you'll be right most of the time. I'm just telling you. Honestly. I laughed. I went in the unit. I was on PCU, the cardiac floor. And I looked up and I laughed. Almost every patient was in atrial fib. Every dang one of them. And I was like, dang, y'all got to run on this. She said, always. All right, so we said atrial fib, didn't we? That's a big one. What do you think the big problem there is?
It not slowing down.
Huh?
Well, it's perfusion because it's not able to open up enough to get the blood in.
All right, let's talk real quick. I'm going to go over this in detail when you come back. Stroke. The reason, or blood clots in general. It could be a PE, pulmonary embolism. It could be a stroke. It could be clots to the leg. The problem is the atria themselves are sitting there quivering. So they're not squeezing the blood down. So the blood is pooling. It's just staying stagnant in there. And you cut yourself and don't wipe it and let it just sit there. What does it do? It clots. We hope it clots. Otherwise, you've been drinking too much or taking too much aspirin or ibuprofen or Aleve, because that will knock your platelets down too. I heard y'all in here. Okay. All right. So the problem with atrial fib is what? Clotting. And so one of the biggest complications we see in atrial fib is a stroke. because if it's untreated and nobody wants to go get treated, then they'll throw clots. And just according to where the clots go from the heart, what damage you get, right? Think about it. On the right side of the heart, where does blood go to? The lung. That'd be a pulmonary embolism. On the left side, where are you going? To the body. You can go up. If the clot goes up to the brain, they're going to have a stroke. If it goes down, what can happen? A bunch of stuff. Is you with me? All right, so you're going to find that one of the big treatments with atrial fib is going to be anticoagulants. So that's another reason that you have to know all about warfarin this semester too. And you got to be able to make those patients understand that they have to have frequent lab appointments. They have to have frequent lab appointments, right? With warfarin, don't they? Because what are we monitoring with warfarin?
They're clotting factors.
Primarily, PT and the one we look at is INR the most. But PT and INR for you, for NCLEX, for warfarin. You've got to know it, and they have to have lab appointments. They can't just call the doctor. They can't just call the doctor and ask them how much to take today. Because the doctor needs to know what their lab was. So they have to keep their lab appointment. And then the lab goes to the doctor's office, and the doctor's office lets them know how much Coumadin to take. Because it varies. And why do you think it varies? What are they eating? And are they eating like they're supposed to? We're supposed to teach patients to be consistent. If you're going to eat leafy greens, you need to eat them routinely. If you're not going to eat them, don't eat them. Does that make sense? Because we're trying to prevent all the ups and downs. We want to keep their blood at a good level where it's not going to form clots and they're going to have a stroke, right? So that's the whole reason for the warfarin, is to prevent the blood clotting, because we can't get the atrial fib controlled or knocked out. They're going to live in atrial fib, some people. And they call it chronic atrial fib. And they live in it. And there's no big deal. We don't get freaked out when somebody's in atrial fib. We get freaked out if somebody's in atrial fib with rapid ventricular response. And that's the diagnosis they're given. And all that means is their rate's above 100. And now let's talk about something and why that's a problem.
Their heart rate?
Yeah, why their heart rate's a problem. Why we get upset when a person in atrial fib has a high heart rate. All right, well, that's a good point, but look at it like this. Ordinarily, what is supposed to happen is your atria are up here and your ventricles are down here. And your atria is supposed to contract blood after it spills down, contracts, and then the ventricles do what? Contract, and they're in sync, right? Well, in atrial fib, there's no atrial contraction. So you've already lost about 30% of your cardiac output already, just because you're in atrial fib. Now, speed this up. And so, are they losing even more cardiac output? Does that mean they're losing perfusion? They start to feel bad because they don't have good cardiac output. And if their body's not getting oxygenated, is their heart getting all the oxygen that it needs? Mm-hmm. There's no time, because remember, the heart gets its blood supply from the coronary arteries during diastole. So if you increase the rate, how long is diastole? So does that make sense? So in atrial fib, they're losing their cardiac output. If their rate goes up, they're losing their cardiac output anyway. And your body is pretty good at compensating a little bit. But if you bring the rate up, you've lost a lot, too much.
Is that what they call Vitiated?
No. We're going to cover that next time. That is fun.
What'd you say?
We all like to take care of dead bodies in theory, but when it happens, I don't know where y'all go. I'll be standing there and I'm like, where are y'all? Why am I the one here? You know, the first one on the scene. I'm like, I'm older than all you students, and I done made it to the room before every one of y'all. You know why? In theory, this is fun, but in the real world, you're like, that's a dead body. You know, I get it. I was like that too for a long time. Look, Kelsey's not. She's just me.
It's really funny, actually, because that's what we have to do. We have to do postmortem, and like I always get like.
Well, I'm gonna save them. What are you talking about,
We do
postmortem?
postmortem, so we extubate. I had an EMT.
Where do you work? I won't go there. I'm teasing. I'm teasing.
I had an EMT student extubate a patient, and he had no idea what he was doing, and it was hilarious to see his face with extubate him.
Oh, brother.
But no, codes suck, no matter what it is.
It does,
doesn't
and
matter
that's
if
what
they
she
suck.
said. What you say, Vitiated is it can be a dead rhythm. And we cover all ventricular rhythms in level 4. We'll cover atrial rhythms right now. Which one did I tell you to look real hard at? We're talking about atrial fib. So let's talk about atrial fib just a little bit, and then I'm gonna show it to you and explain it to you when you come back. Okay? So far you've learned that atrial fib, some people live in it, right? The problem with it is they can clot, and they need anticoagulants. And we typically don't treat them in a hospital unless it's new atrial fib and they're wanting it out of it. Some people we can get out of it. Sometimes the treatment works and we can get them back into normal sinus rhythm. So that's when we're treating them in a hospital, is it's new and we're going to see if we can get them out of it. The other reason we see them in the hospital is because their heart rate goes up and they can't tolerate it. And so we have to treat them to get their heart rate back down and try to figure out why that's happening. Does that make sense? Okay. It's the most common chronic arrhythmia. Make sure you know that. Atrial fib. And the other one that we're going to look at briefly, and it's not even in your book, and I don't know why. We teach it in the hospital. We see it in the hospital. It's atrial flutter. And it's on the PowerPoint, and I'm going to show it to you because I want you to know what you're doing out in the hospital. Atrial flutter. And let me tell you about atrial flutter. The first word when you're classifying rhythms is where the impulse originates from. So it's coming from the atria. And the second word is the type of cardiac activity. So flutter. So instead of fibrillating, the atria is fluttering. So it's regular rhythm. It's real interesting when I show it to you. But this one, atrial flutter, is the most short-lived arrhythmia that you can have. If someone's in atrial flutter more than 24 hours, that's not common. It can happen. I've seen it, but it's not common. Typically, if they're in atrial flutter, they're going to go into atrial fib. Okay? Or they're going to revert back to sinus rhythm. Very interesting. All right? So those are the three main ones. I'm going to introduce you to junctional rhythms. Do y'all remember that the AV node is second in line to the SA node? Do y'all remember that? Mm-hmm. And we said that the SA node paced the heart 60 to 100 and the AV node could only do 40 to 60. Do y'all remember that? Well, we found out that the pacer cells are not really in the AV node. They're in the junction, the AV junction. And that's why they call what we used to call nodal rhythms is now called junctional rhythms. And the reason I tell you that is there are old nurses and old doctors that still call them nodal rhythms, and you'll be going, what? And they're talking about the same thing, okay? So if you ever see a junctional rhythm, understand that something has happened to that patient's sinus node, and you got to tell somebody, okay? Because why is now the junction pacing the heart, okay? And so I'm just gonna show you that, and I'm just telling you this because I want you to be a good nurse. And also, we had an event at one of the hospitals to where a night shift nurse didn't want to call a doctor in the middle of the night. The patient went into a junctional rhythm. He went and assessed her, and her blood pressure was fine. She said, honey, I'm fine, ain't nothing wrong with me, but she had diabetes, kidney disease, and everything else. She probably couldn't feel if anything was wrong with her. And so he felt like, this nurse felt like he could wait until about 6:30 to call the doctor. And this happened at like 1 something in the morning. And so this lady had had an MI in the night. It wasn't a good thing. And so he didn't remember that from his learning. He was a newer nurse. So I have made it my practice to say, no, I don't expect you to really know that's junctional rhythm. But darn it, if the telemetry tech tells you somebody's in a junctional rhythm and it's new, you need to call your supervisor and then call the doctor. Does that make sense? It is significant, is what I want you to know from me to you. All right. Now, and you see a junctional rhythm commonly after a code. It's interesting. So where do you think the damage was? The SA node. All right. So the other one I'm just going to introduce you to, and we will cover next semester hot and heavy, but I'm introducing it to you this semester because the location is in the atria. There's an umbrella term that I'm going to teach you called supra, means above, ventricular tachycardia, SVT, SVT. S is in Sam, V is in Victor, T is in Tom. It's called SVT, and that's a big old term. And all that means is the patient is having a tachycardia that is coming from above the ventricles. It has taken over pacing the heart. That irritable site has taken over. Whoever can pace the patient's heart the fastest is in control. And who is that supposed to be?
SA node.
SA node. But if you irritate a part of your heart good enough, that irritated site says, I got this, I got this, I got this, and it overdrives the SA node. And if you're going about 200 a minute, your heart is that a problem? Mm-hmm. Do you, even you, lose your cardiac output if that happens? Mm-hmm. Yes. And this commonly happens to young females. And it used to happen to me all the time when I was a new nurse, and my lips would start turning blue. And they go, what's wrong with you? And I go, it's okay. My heart's running away from me. They making me work night shift, and I'm on about my 5th cup of coffee. You know, they're like, you got to stop that. And so I would bear down like I'm having a bowel movement sometimes. When I have stomach issues, I couldn't. So here's what I do when I couldn't. When that was happening to me, I did what kids do. Squat. It increases the pressure in your chest and can help you get out of SVT. And so it's like a vagal. You need do a vagal maneuver, because when we do a vagal maneuver, acetylcholine is released. Okay, and what is that? That's our brakes. So what are we trying to do in SVT? You're trying to slow the heart. And some people will cough to try to make it stop. If you're in it for too long, you need treatment. And so my heart was healthy at the time, so I didn't let it bother me much until they told me how bad I looked, and I don't like looking bad. So I went and got some treatment eventually. But anyway, and I quit doing the coffee.
Is that when they give the ginseng?
Yes.
That's one thing that I need some calls for if anybody ever gives.
It's fun.
Yeah.
And we'll learn about that in level 4. I'm just going to introduce you to it. So what are the ones you need to look at this weekend? PACs, atrial fib, atrial flutter. Okay, in that order. And the most common one's the one that's mostly tested, right? Okay. I know better than to start looking at these dysrhythmia slides today. Y'all wouldn't remember a word I said. And so we'll do that when I come back. We'll go through that, and then we're going to knock out